So just to remind you, it was just a few years ago that this really comprehensive summary of the cooperative group experience across a span of decades in phase 2 clinical trials using therapies that were ultimately deemed to be ineffective. This is the outcome data in metastatic melanoma, 25% 1-year survival rate, median progression-free survival whenever you did the first radiographic restaging assessment, so 6 weeks, 8 weeks, in this case 6 weeks as shown here. And this is thousands of patients treated, as you can see from how smooth these curves are. This is the natural history of metastatic melanoma. And just to give you a quick sneak peek about where we are heading and where we think we are already, at least in terms of patients that we're treating in clinical trials with what we think are the next quantum leap in terms of therapeutics. Stage 4 survival in 2 combination phase 1 studies that I'll come to later in my comments have produced 80% 1-year survival rates, which is just astonishing to consider given the short number of years that have passed. And in terms of progression-free survival, and I'm sticking here with 12 months because that's where we have sort of maturity of data with these early attempts to combine some of the therapies that have shown single-agent activity. You see the progression-free survival data. I mean, these data points are actually pretty much spot on. I've just created this cartoon to give you a feel for what's been accomplished so far. So is there still room for improvement? Absolutely, there is. And the impact of these therapies in the adjuvant setting could be even greater than the impact in the overt metastatic setting. But I'll try to fill in the gap for you here in terms of what we've accomplished and how we've done it. Now, to be clear, progress has been staggered across the melanoma population, at least as it pertains to molecularly targeted therapy, because we now currently subset patients along the lines of this type of classification as described by the TCGA dataset, but supported by 2 other fairly large sequencing studies that have been presented and published contemporaneously. You see our largest oncogene-defined subset being the BRAF mutant population in the middle, and flanking that is perhaps a larger group than had been previously appreciated, with NRAS mutations representing approximately a quarter of the patients, and thereby about half of the remaining so-called BRAF wild-type patients. And what hadn't been appreciated in years past, but has been corroborated in each of these large sequencing studies, is the frequency of loss of function of NF1 mutations, and the fact that they seem to pretty clearly connote a distinct subpopulation. Note there that they can have BRAF alterations, but these are not V600 activating BRAF mutations that associate. What are found in conjunction with the NF1 mutations are the so-called low-activity BRAF mutants, and that's known, for example, to also be able to co-occur with an NRAS mutation. On the far left, there's a couple of cases that back that up as well. So in general, the strong oncogenes, BRAF and NRAS, are mutually exclusive events, and you would say the same of NF1, except that it can cross a little bit, especially with these low-activity BRAF mutants. Below that, you see a depiction of the genetic landscape beyond the common driver oncogenes. And again, before leaving this slide, what I'll expand upon is the successes that we've had thus far in targeting the BRAF mutant population, as is well known. And we're optimistic that we're going to be able to make some inroads into the other MAP kinase pathway-driven subsets shown here, NRAS and NF1 mutant populations. But I won't belabor the point that single-agent MEK inhibitors have shown a signal in that population. We have, for example, with the Novartis MEK inhibitor, MEK162, the most robust signal, 20% response rate in an NRAS mutant population. It's not to say that there aren't responses in some of the NF1s, but that is the building block, at least for now, that we're thinking around building some of the targeted therapy combinations that we hope with 2 drugs will give us what we get with essentially 1 drug with BRAF inhibitor-based therapy. I'll come back to the topic of trying to think about cleaning up some of the other somatic genetic alterations as therapeutic targets for combination targeted therapy a little bit later. So our biggest group, as I've said, are those with BRAF mutations. The vast majority of them have mutations at the V600 position. In melanoma, that's particularly the case, whereas in other tumor types where BRAF mutations are found, the distribution doesn't necessarily follow the depiction that I've shown you here. The so-called selective BRAF inhibitors seem to be clinically and biochemically relevant only for those tumors that have V600 position mutations. Somewhat amazingly, BRAF mutations at the 599 position or 601 position, which are pretty clearly activating, are not responsive to these same drugs. And as you get a few residues away from that, the same holds. Not every one of these mutations has been characterized to that extent, but that statement continues to hold thus far. And so we are hopeful that we would still be able to use the presence of these other mutations in exon 15 on the right or exon 11 on the left as sort of therapeutic targets, at least for targeting the MAP kinase pathway, but we're going to need to be targeting downstream based on the preclinical evidence. Several of these mutations that have been shown to be resistant to the selective BRAF inhibitors are, at least in the context of cells, responsive to MEK inhibitors, and there are a few anecdotes of patients treated that have been responsive. So this is a relatively small subpopulation in melanoma, larger subpopulation of those with BRAF mutations in several other tumor types, including non-small cell lung cancer. But it's a bit of a work in progress to really nail down the responsiveness even to MEK inhibitor therapy. So zeroing in on the BRAF mutant population, which admittedly leaves out 50% of the melanoma population in terms of therapeutic advances to the same degree, here's the depiction of the reliability of initial anti-tumor activity of selective BRAF inhibitors. Here I'm showing you vemurafenib, but dabrafenib produces essentially identical looking waterfall plot. A very small fraction of patients who have de novo resistance to therapy and sort of similarly small fraction that have complete responses, which we now know to be the most durable responses, and the vast majority, as you see, with some degree of regression, but certainly incomplete and leaving plenty of room for improvement. If you look at what MEK inhibitors have accomplished in the BRAF mutant population, which is the most responsive subset to single-agent MEK inhibitor therapy, in a BRAF inhibitor naive setting, you see that the anti-tumor activity is comparable, but not quite as robust. I would summarize this data to say that there's about 80% of the efficacy that I just showed you on the previous waterfall plot shown here. So a larger fraction of patients with de novo resistance, lower objective response rate, and in general, the whole waterfall plot is somewhat shifted, if you will, compared to the BRAF selective antagonists that have a bit more robust activity. The toxicities are also different with these therapies. BRAF inhibitors induce toxicities such as arthralgia, rash, photosensitivity, common to vemurafenib, but shared largely, particularly rash, and to a lesser degree arthralgia for dabrafenib. But these toxicities, and particularly the cutaneous squamous cell carcinomas, we think are a consequence of MAP kinase pathway activation. That many of you well know this story, but just to briefly describe it in a couple of figures. Selective BRAF inhibitors are truly inhibitors in the context of oncogenic BRAF. There's little doubt that these drugs in that cell context will reliably inhibit the MAP kinase pathway, a topic that I'll reaffirm for you in a moment based on actual data. In the context of high RAS GTP, either because of receptor tyrosine kinase signaling or because of a RAS mutation, these same drugs, and probably largely due to their interaction with BSiRAF, actually activate the pathway. But there is some evidence that wild-type BRAF can also be stimulated in a similar fashion. So in the setting of high RAS GTP, RAF is forced into dimers, which is how it normally signals. And in the setting of high concentration of RAF dimers, these drugs at increasing concentrations will actually engage one of the two monomers in the dimer and actually transactivate, if you will, the complex and create more signaling. So not true in low RAS GTP when RAS exists largely in monomeric form, which is the state on the left-hand side. So these drugs have a very different biochemical effect in different cellular contexts, and we think that has a lot to do with the issue of the therapeutic index of these drugs. Because MEK inhibitors, and for that matter ERK inhibitors, which we currently have in phase 1 testing as we speak, these drugs block the MAP kinase pathway really independent of upstream genetic alterations or RTK activation. So it really does not matter what the RAS GTP state is, for example, in cells. They will block the pathway in any setting. So when you think about BRAF inhibitors and MEK inhibitors and ERK inhibitors as well, the difference here that I'm alluding to is not so much their ability to inhibit the pathway in the tumor. The issue is that in normal tissues, the vectors point in essentially opposite directions. And so when you try to administer a maximum tolerated dose BRAF inhibitors versus MEK inhibitors, what limits you in terms of toxicity are the consequences of, if anything, MAP kinase pathway activation or off-target effects for BRAF inhibitors, but it's inhibition of the MAP kinase pathway that's causing toxicity with the MEK and ERK inhibitors. And that is why we think the therapeutic index is a bit different between these two strategies, because of course on the surface and in isolated cell culture looking just at BRAF mutant cells, you wouldn't understand why there would be a difference in terms of therapeutic impact. So backing that statement up is the toxicity profile of a MEK inhibitor such as trametinib, which is the one that's now FDA approved. It does cause rash, but a very different looking rash, of a more follicular and even acneiform rash, causes diarrhea that the BRAF inhibitors don't cause, and so on. Again, we think all of this is the consequence of inhibition of the pathway in normal tissue. Now, going back to the issue of what BRAF inhibitors accomplish and don't accomplish, I made the comment that they reliably inhibit the MAP kinase pathway in BRAF mutant cells, and that's true in cell culture, it's true in xenografts, and it's true in patients as well. What I'm showing you here are a series of patients, 23, who had tumor biopsies before treatment and early on therapy after 2 weeks. This is at the tail end of the phase 1 study with vemurafenib, where we performed these biopsies when we were already seeing objective responses to therapy, but we were trying to map out the issue of sort of the reliability of the pharmacodynamic effect and to try to understand if there was variability in that measure. And as you can see, there really wasn't a lot of variability in terms of the magnitude and the consistency of MAP kinase pathway inhibition as measured by ERK phosphorylation. And I'm not showing you here, but I could, markers such as cyclin D expression or Ki67 that corroborate this finding as well in terms of statements about MAP kinase pathway output. At the time of disease progression, the MAP kinase pathway reawakens, not in all cases in the setting of single-agent BRAF inhibitor therapy, but in a significant fraction. This data is displayed on the right-hand side as well, where you see most instances of reactivation of the pathway to a moderate or marked degree, but a few instances of persistence of inhibition of the pathway, where you would reason that the tumors are probably using MAP kinase pathway independent mechanisms to circumvent treatment. The mechanisms that have been described by our group and others are shown here. Now, this is not in any way yet a complete catalog, but these are the mechanisms that have been demonstrated both preclinically and validated at least to some degree in patient tumor specimens as mechanisms by which MAP kinase pathway reactivation can be achieved. But if you were to ask how many patients or what fraction of patients can you find these mechanisms, and we're probably not at even 50% yet if you were to aggregate all of the human data that I'm trying to summarize in this cartoon. The most common alterations that occur, perhaps the most common, are the BRAF splice variants, which is what I'm alluding to here with these two BRAF molecules with a bite taken out of them. These are truncating alterations. They're not mutations. They're splicing out of upstream elements of BRAF. I say upstream, meaning not in the kinase domain, that seem to then facilitate RAF dimerization even in the setting of low RAS GTP. And that allows RAFs to then signal even in the face of the drug, and that's been pretty clearly demonstrated biochemically. And then in the clinic, it's very clear that the splice variant shows up pretty commonly. About 30% of patients, it appears, have expression of the BRAF splice variant at the time of disease progression. The presence of an NRAS mutation is another notable finding in terms of its frequency. About 20% of patients' tumors have an NRAS mutation at the time of disease progression. And this is an interesting subset because it appears that these tumors bear both a BRAF and an NRAS mutation. So in other words, persistence of oncogenic BRAF, but now also showing the most common Q61 position mutations in NRAS that we otherwise find as single oncogene drivers in a distinct subset of melanomas. There's data preclinically that actually suggests that the presence of both a BRAF and an NRAS mutation, even in a P16 null melanocyte, is actually deleterious in the sense of not conferring a growth advantage, to have both quote-unquote strong oncogenes present in the same cell. And it could well be that this is a pre-existing subpopulation admixed with the tumor that is largely BRAF mutant but NRAS wild type that has a growth disadvantage in terms of the natural history of the disease, but under the selective pressure of therapy, when you're essentially eliminating the effect of oncogenic BRAF with the BRAF inhibitor, you're now creating a cell that is effectively an NRAS mutant melanoma, which we know certainly can thrive perfectly well in real patients. And it's this notion about a clonal subpopulation that may be emerging that I think partly supports the idea of the concept of intermittent therapy or withdrawal of therapy to try to allow clonal redistribution, repopulation, if you will, allowing the dominant clone potentially to grow back, but then to reinstitute therapy at that time, and allowing this dual mutant clone to suffer, if you will, as you would anticipate it might, given that it doesn't ever really manifest as the dominant clone in the natural history of the disease to have a dual BRAF and NRAS mutation. So you would think with all of that evidence of MAP kinase pathway reactivation that a simple strategy would just be to treat these patients with a MEK inhibitor following progression on a BRAF inhibitor. And unfortunately, that doesn't work. As shown here on the left-hand side, a cohort of patients who had failed BRAF inhibitor therapy treated with single-agent MEK inhibitor, the same drug, trametinib, that I've shown you before that has quite robust activity in the treatment-naive setting. In the refractory setting, it does not. The two responders shown here, in fact, had stopped their previous treatment because of toxicity, not because of emergence of resistance. If you use a combination approach, trying to use, in this case, dabrafenib and trametinib together, so consider that sort of maintaining the BRAF inhibitor and adding the MEK inhibitor, you do get some anti-tumor activity. It's not terribly robust, but there's something to look at there. As a statement that the reactivation or biochemical reactivation is probably functionally important. At least I would use this data to make that statement. I wouldn't claim that this is a particularly robust therapeutic strategy to be trying to deliver in terms of an approved regimen for salvage therapy. Rather, we've paid much more attention to the idea of using this combination approach, BRAF inhibitor, MEK inhibitor, together up front in patients who've not yet received a BRAF inhibitor. We performed a phase 1 and then randomized phase 2 trial with this combination, able to administer full doses of both drugs, which I'll remind you in a moment why we're able to do that. And in the phase 2 portion of the study, randomized patients to receive the two-drug combination up front versus dabrafenib monotherapy, which produces, as you can see, a waterfall plot that looks identical to vemurafenib in terms of the spectrum of activity. So interestingly, and I think we were pleasantly surprised to see how good a job the combination does at overcoming even de novo resistance. So now you've essentially eliminated the de novo refractory subpopulation. There's certainly patients who aren't responding, but you're not losing patients to early escape. And then you've increased the fraction of complete and near complete responders in the waterfall plot shifting, and the response rate actually goes up from the mid 50% range to the mid 70% range in terms of confirmed objective responses. Our primary hypothesis in executing this trial was that we would hopefully suppress the MAP kinase pathway reactivation mechanisms and delay the time to treatment failure or the emergence of clinical resistance. And that pretty clearly happened. Patients who received full doses of dabrafenib and trametinib in the green curve versus the group randomized to receive dabrafenib alone in a modestly sized study, I'll admit, clearly different in terms of the progression-free survival experience. And this data was mature to the measure of 14 months by the time we actually presented and published the outcome. So the 12-month numbers are pretty firm for this cohort, and that's a 40% versus 10% progression-free survival rate, which is, I think, pretty clear demonstration of the notion that we can at least partially suppress some of these escape mechanisms. And the toxicity is the sort of kicker in favor of this combination becoming our new backbone. And as I often argue, the backbone to which we will now add third drugs, because the two drugs together are actually more tolerable than either drug alone. And this goes back to the arguments that I was making before about the biochemical effects of BRAF inhibitors being, if anything, stimulators of the MAP kinase pathway, MEK inhibitors being inhibitors of the MAP kinase pathway in normal tissue. We reason that the vectors are essentially canceling each other out to some degree. And that in tumors, of course, the vectors are pointing both in the negative direction, if you will, in terms of being inhibitory. Now, this may actually open the door to the possibility of increasing the dose/exposure of either BRAF or MEK inhibitor in this combination, because I've shown you that we can deliver the two drugs together with efficacy that's apparently greater. If you were to ask how many patients had dose-limiting toxicities in the phase 1/randomized phase 2 trial, We treated, I think it was 71 patients before progressing into the randomized portion of the study to sort of confirm the tolerability as well as to look at some more translational endpoints in that study. And we didn't see a single dose-limiting toxicity in 71 patients. So that's a pretty low DLT rate, and by Bruce's standards, maybe too low. I mean, by conventional cytotoxicity standards, it's definitely low. So there may be the opportunity to escalate, and that's an opportunity that hasn't been entirely leveraged, although I will mention that the third selective MEK inhibitor, BRAF inhibitor to enter clinical development, LGX-818, from Novartis, and paired with their MEK inhibitor, MEK162, coming later in the game actually created the opportunity to try to explore that. And so in an ongoing phase 1 study that we've been conducting with that pair of BRAF and MEK inhibitors, we've actually exceeded the single agent MTDs of both the BRAF inhibitor and the MEK inhibitor by pushing the doses higher to see if we can potentially mop up some residual MAP kinase pathway output and achieve an even greater degree of anti-tumor efficacy, admittedly compromising some of the tolerability that this regimen seems to have. Now, you might ask then, are we done with the MAP kinase pathway? And before I leave this portion of the talk and move into the next, the preliminary answer looks like no. We've been collaborating with Levi Garraway for the past couple of years now around BRAF inhibitor resistance and looking at genetic explanations for that. In the first few patients for whom we have paired tumor samples before and after BRAF-MEK combination therapy, mind you, it takes longer for these patients to progress, which is a good thing, but also means longer for us to accumulate a sample set. This is the first 4. We have a handful more that are in the queue right now being sequenced at the whole exome level. And what comes out of that, looking across the whole exome, interestingly, are 2 MEK mutations, top and bottom, and then BRAF amplification and a previously described BRAF splice variant. And you might have guessed or hoped that we wouldn't see the suggestion of BRAF-mediated mechanisms if we're co-treating with a MEK inhibitor. But it's fairly clear that they're showing up at the time of resistance, not detectable in the pretreatment specimen. The MEK mutations, I think, are perhaps what you would have maybe hypothesized could occur. And to be honest with you, I've almost been rooting for those, because now this gives us perhaps the first chance to think about deploying targeted therapies to deal with refractory disease in a way that's at least somewhat analogous to other oncogene targeted therapy success stories, because I've shown you the evidence so far that suggests that BRAF targeting is anything but that. We put selective pressure on the pathway, and what emerges is this chaotic array of mechanisms that really don't lend themselves to a sort of single unifying approach in terms of what a salvage therapy strategy or drug might look like. But if we force more of these MEK mutations, we might be in business in terms of either next generation MEK inhibitors or ERK inhibitors as being well poised to intercept the effects of those. So how might we deal with it in the meantime? HSP90 inhibitors might actually be perfectly well deployed in this setting, and we have a CTEP-sponsored study that we're writing up from concept to protocol as we speak, which will begin in a handful of months, adding an HSP90 inhibitor to BRAF-MEK combination therapy. So now this is one example of a triplet. Admittedly, HSP90 inhibitors have relatively broad effects, but we're interested in downregulating BRAF and oncogenic BRAF specifically as the strategy here, and this is one of the few ways we could think about actually just dialing down the expression level. I've mentioned already that ERK inhibitors are in clinical development. They may be a useful salvage therapy, as I've alluded to, but it may be, in fact, that their best use is going to be to substitute them in for the MEK inhibitor in a BRAF-ERK combination as a way of trying to get more complete capture or control of the MAP kinase pathway. I'm not showing you the preclinical data that suggests that, but the preclinical data does suggest that ERK inhibitors can do that. Whether they have therapeutic index at all as single agents is what we're trying to establish in the ongoing phase 1 studies. But you can imagine that if we prop up the MAP kinase pathway with a BRAF inhibitor in normal tissue, we might actually make an ERK inhibitor more tolerable as we do MEK inhibitors. And then a new class of RAF inhibitors may be emerging. We have yet to demonstrate in the clinic that drugs that block RAF dimerization that you would anticipate not only to block oncogenic BRAF, but probably wild-type RAF signaling as well. We have yet to demonstrate that those will actually have a therapeutic index, but the hope of them is that they could intercept in a more complete way what RAF is capable of doing, and including CRAF, which has long been hoped to be or thought to be a target in various tumor types. There are what seem to be fairly clear suggestions of MEK-independent functions of RAF that, of course, MEK inhibitors then won't deal with, that these types of RAF inhibitors potentially could. But I wouldn't put too much emphasis on the notion that we know or can expect that this approach will have tolerability in terms of normal tissue effects. So in leaving this major portion of the talk and just sort of moving to the last set of comments that I wanted to make, we have these fairly obvious co-targets to consider in the BRAF mutant population in particular. I'll point your attention to the bottom of the slide where we see how frequently CDKN2A is inactivated. And we think this, along with cyclin D amplification, which you can see here represented with just a couple of cases in this figure, but also CDK4 mutation or amplification can occur in a handful of cases. They all seem to triangulate around a strategy of targeting CDK4 therapeutically, and there's emerging preclinical evidence in support of that that I won't review today. The PTEN deleted subset, or the ones with inactivating mutations, we've known about this group for quite a while. What we hadn't known prior to the large-scale sequencing studies is how frequently they are genetically altered in addition to CDKN2A. So notice the near complete overlap of these alterations with CDKN2A alterations. AKT3 is amplified in a subset, distinct from the PTEN deleted subset. So we do think there's a clear smoking gun genetically, and there's plenty of preclinical therapeutic evidence that would suggest co-targeting the PI3 kinase pathway could be useful, but you're all perfectly familiar with the challenges that have been visited upon the field in terms of trying to combine, for example, MEK and PI3K inhibitors. So in melanoma, we struggle a little bit with sort of what strategy amongst the available therapies in the PI3 kinase pathway to deploy for this purpose. You could argue that at least for this small subset that have AKT3 amplifications, we'd like an AKT3 inhibitor that's selective, and such a drug does not exist currently in clinical development. Lastly, I'd just mention, based on somatic genetics, you can say that P53 is generally intact in this disease. That's, of course, been known for a long time. And MDM2 can be amplified in a subset. That's a distinct group. And we reason, and the preclinical evidence supports, that MDM2 antagonists actually would be rightly pointed at the melanoma population, not as single agents so much, but in combination with optimal MAP kinase pathway targeted therapy. And we've published in our group preclinical data that supports that notion, and that's another regimen, combination regimen that'll be moving forward. So we actually have active trials that are launching as we speak within the next few months, phase 1b type studies to try to validate the combinability of triplet therapy, BRAF, MEK, plus these points of interventions. But of course, we have to be mindful of who should be getting these combinations, right? Not assuming that there's ever going to be a one-size-fits-all strategy once you scale up to that order of magnitude of drugs. So a few comments about immune therapy, and then a stab at a grand unifying theory for next steps in melanoma treatment, which is my assigned title. The major breakthrough, as many of you are aware, in immune therapy in melanoma, and now finally spreading to other tumors to some degree, has been the elucidation of the so-called immune checkpoints. I'm showing you here just the dominant negative regulators of T-cell function, CTLA4 and PD-1. But it's very clear that there are activating receptors as well, beyond just the critical co-stimulatory CD28, for which agonist antibodies may well be targeted or rationalized, and several of those, in fact, are in clinical trials. But interestingly, and I think not necessarily predicted based on preclinical evidence that exists regarding these various strategies, it's the inhibition of the negative regulators that, in fact, that has yielded the clearest clinical signal so far. And this is with several agonist antibodies against other targets being in the clinic now for a couple of years already. Ipilimumab has a real signal in this disease. Of course, it's FDA approved now, but you might say, yes, it's a real signal, but it's modest. The improvement in overall survival, by that I mean the relative impact, the fraction of patients who are alive who otherwise wouldn't be on ineffective control arm therapy, in the 10 to 15% range. Progression-free survival data supports a similar summary statement, and even the response data would support that notion that single-agent ipilimumab produces clear responses anyway in about 10% of patients. So clear proof of concept, and the survival data speaks to the idea that response and PFS don't maybe completely measure the benefit of this therapy. But it's the PD-1, PD-L1 drugs that have absolutely sucked up all the oxygen in the field in the past couple of years, and for good reason. So the statements that I'm going to make about these drugs in the next few slides are really meant to apply to this whole class of drugs, nivolumab, MK-3475, and the Genentech PD-L1 drug shown here. They really have produced very comparable efficacy signals, so I'm not going to torture you with each of the data sets, but trust me that they align fairly well. This is the MK-3475 data, single agent, in a phase 1/2 trial. Most of these patients by this, included in this figure though, were treated at a uniform dose. All metastatic melanoma patients, and you can see them broken up in color here by prior ipilimumab therapy or not. Really impressive initial anti-tumor effect, and something that had never been shown before. In fact, I would say this is now the first time that you see immunotherapy in melanoma or elsewhere being sort of summarized with a waterfall plot, which we otherwise we use as our way of trying to quickly make statements about the anti-tumor effects of targeted therapy. Really quite impressive. And it's not at all clear. I made the comment before about BRAF inhibitors and complete responses being the most durable, which does seem to be the case, and true for BRAF MEK also. It's not at all clear that you need to have a complete response with this type of therapy to have a durable response. And that's alluded to here. If you take a cohort of patients who had objective responses from the previous figure and then follow them and ask the question of how long do these responses last, the answer is they appear to last a fair duration of time, admitting that this is, at this point, the 1-year mark, relatively immature data. But we know with nivolumab, which entered clinical development a bit earlier than MK-3475, that these responses certainly can hold up between 1 and 2 years, and how much longer they'll go, we're still trying to define. But the reliability of upfront anti-tumor effect appears to be greater with these drugs, and the durability seems to hold up like immune therapies have historically in terms of those who do respond. Just a quick flash of nivolumab single-agent data, which is, I would say, comparably active. The issue here is that you're looking at quite a broad range of doses that were evaluated in a phase 1 trial, so that a little bit confounds what you're looking at here. Also, a little bit more of a mixed patient population included in this study compared to the previous MK-3475 data that I've shown you. But I show you this partly to then impress you with what the combination of ipilimumab, CTLA-4 blockade combined with PD-1 blockade it looks like. Here now showing you nivolumab combined with ipilimumab. So I just showed you nivolumab's sort of single agent profile, so reasonably robust. Ipilimumab, again, there aren't even published waterfall plots, but not published, not presented waterfall plots to pull, but I can tell you it's not terribly robust at that way of expressing the data. But here, in a combination phase 1 study targeting melanoma specifically, the combination looks quite robust in terms of anti-tumor activity up front. Interestingly, the fraction of patients who have some degree of regression compared to single-agent PD-1, for example, the Merck PD-1 antibody, doesn't look different. So the overall fraction of patients going in the right direction, if you will, but it's the complete and near complete response element of this data that has really captured so much attention. Admittedly, the toxicity of the combination also creates some caution, and you could imagine that there's a reasonably high bar if the toxicity is additive or more when giving this type of approach together, that we're really going to need to see randomized data supporting a better outcome by giving a combination versus the default of sequential single-agent therapy. So in closing, and I hope to set up David's comments with this last couple of slides, we've been very interested in our group on the topic of really trying to understand the potential intersection between these two classes of therapies. So what I'm going to show you on the next 2 slides takes you back to BRAF inhibitor therapy, but really trying to map out what we now refer to as the immune consequences of BRAF inhibitor therapy. David and collaborators had shown years ago that the MAP kinase pathway does regulate the expression of MITF, the master regulator of the melanocyte lineage, to a large degree. And oncogenic BRAF actually suppresses MITF. What's a little curious about that is that MITF itself can be an oncogene in melanoma. That's been well demonstrated by David and corroborated by many others. It can in fact be amplified in a distinct subset of tumors. So you might wonder, well, why would it be that oncogenic BRAF would suppress this putative oncogene? And I won't dwell too much on that puzzle, other than to say that the phenomenon of suppression of MITF has been well mapped out. And so we basically sought to confirm, you could call it a hypothesis, but we thought basically the obvious confirmation of this in humans would be to verify that MITF expression goes back up after BRAF inhibitor therapy. And that's what we've seen quite consistently, as you see here, across a cohort of patients, looking at pre-tumor biopsy and on therapy tumor biopsy for individual patients that are displayed here. We essentially always see an increase in MITF expression, 2-fold to 10-fold. And David's better poised to make the comment about how meaningful that is, but we've asked him, and he tells us that all of that is potentially meaningful in terms of transcriptional output of MITF target genes. And we've corroborated that, at least in humans, that if you look at the melanocyte lineage antigens, GP100, for example, a high fidelity reporter of MITF output, you see increases that are absolutely reliable across a cohort of patients, looking at 1 to 2 weeks of therapy, biopsy then compared to the pretreatment specimen from the same patient. We see increases of 10 to 100-fold in markers like GP100. Here's an example of MART1 increase that's fairly obvious in this single instance shown here. And so corroborating this notion that there's an interplay between BRAF and MAP kinase pathway and MITF and these antigens, one wonders whether that alone might be a phenomenon that one could try to leverage in terms of then co-administering immune therapy to try to leverage what might be a more immunogenic phenotype of these tumors. But it actually appears that there's a bit more going on, and I would sort of put this as a distinct phenomenon that we have yet to link the two. But what we see early on therapy, here's an individual example, and here's a report of a cohort of serial tumor biopsies, is a really robust CD8 positive T cell infiltrate at these same early time points, 1 or 2 weeks of therapy. I'm not showing it here, but there's a relative paucity of macrophages or other cell types that you would anticipate might be coming in mopping up dead cells. This is at very early time points when not a lot has happened in terms of tumor regression. And if you look at markers of activation or exhaustion, PD-L1 on T cells, or PD-L1 on tumor cells, which is what I'm showing you in this summary figure and in this individual figure here, you see that these T cells that are coming into the tumor have markers of both activation and exhaustion, which might suggest to you that yes, they're influxing into the tumor, but perhaps they're not optimally active when they get there, maybe leaving room for the notion of adding an agent that could try to further enhance their activity. And it's obviously a fairly tantalizing observation that there are some cases where PD-L1 on the tumor goes up early on therapy, because this might be a subpopulation that actually where we create with BRAF inhibitor-based therapy a potential response to PD-1 and PD-L1 targeted therapy, right? So we know that those drugs have activity on their own, but we also know that there's a subset of patients who don't respond. And there's been some data linking PD-L1 expression on the tumor to response, reasonably convincing in the first pass. And so we might actually be able to convert some of the non-PD-L1 expressors to expressors, which is one of the rationales behind this. Now, I'm going to leave this topic on this slide. There's a lot of questions to be sorted out still in terms of how to deliver this type of combination. Should you be giving both therapeutic strategies simultaneously from day one? Should you be trying to load up the immune therapy and spritz in targeted therapy intermittently to try to re-induce this phenomenon of antigen upregulation and T cell infiltrates intermittently? And all of these things are still on the table, and we're going to try to explore as many of them as we can over the next calendar year in several different phase 1b trials. But this is obviously a hypothesis that we and others are quite excited about. So I'll conclude with fairly obvious points that, at least for the BRAF mutant population, we've made clear inroads in terms of targeted therapy that impact outcomes and in a marked way in terms of at least early measures of disease control and survival. For BRAF wild-type patients, that's where we particularly rely on the advances that have been made in terms of immune therapy. We do think that there's a rationale for combination there, and although I didn't have an opportunity to visit it today, we think that strategy may actually be deployable even in the BRAF wild-type population, thinking about MEK inhibitors or MEK inhibitor-based therapy as a point of intersection with immune therapy. Several, including our groups, have reasoned that MEK inhibitors actually might be poisonous to effector T cells, but in the aggregate, in terms of overall net effect on tumor microenvironment as well as T cells, actually it's not at all clear that that's the case, and it may be a perfectly reasonable intersection, at least to investigate preliminarily. Thanks for your attention.
Yes, so we'll come over to you first for a quick question.
Thanks. Very, very nice and clear talk.
Thanks.
I had a question about your BRAF inhibitor acquired resistance portion. So I think you clearly stated, if I understood correctly, that acquired resistance to BRAF inhibitors is largely due to other stimuli of the MEK pathway, whether it's CRAF or NRAS mutation, et cetera. And I think you also said that MEK or ERK inhibitors should block regardless of what the upstream stimuli are. So I think that all makes sense.
Right.
But then you went on to show that with BRAF inhibitor-acquired resistance, trametinib as a single agent wasn't effective, and that trametinib plus a BRAF inhibitor is more effective somewhat. So why would that make sense?
Yeah.
I mean,
So I showed you the evidence early on in my talk that just in the BRAF inhibitor naive setting, a MEK inhibitor has activity, very clear, FDA approved for that purpose, but not quite as robust as a BRAF inhibitor. So I would suggest that at maximum tolerated doses, a MEK inhibitor is able to block the pathway to a reasonable degree. Let me throw a number at you and suggest that it's sort of in the 80 to 90% pathway inhibition range, and there's actually biopsy data that supports that, versus the 90 to 95% pathway inhibition that we, by semi-quantitative measures, that we've mapped out with BRAF inhibitors. That's a lot to ask a MEK inhibitor to be able to control the output of the MAP kinase pathway, now when it's been further activated, if you will, by additional means. So you withdraw the BRAF inhibitor. So now you've got V600E kicking away again, and you've got the opportunity for an additional measure of MAP kinase pathway activation to be also contributing, through the mechanisms shown there. To ask the MEK inhibitor with its 80 to 90% pathway inhibition to capture the MAP kinase pathway output adequately, I think, again, that's a lot to ask. Not to say that an ERK inhibitor can't, and we're interested in that possibility, but we've learned in this field, and I didn't torture you with all the negative data that we generated years ago with sorafenib before I came to Mass General. I left that behind. But there it's fairly clear that sorafenib, for example, can produce sort of very moderate degrees of MAP kinase pathway control in this same clinical context, maybe 50 to 60%. We've learned that you need really high degree of MAP kinase pathway inhibition. And when I showed you 90 to 95% inhibition with vemurafenib, what I didn't say on that slide, but in half my talks I usually remember to say, is that we actually think that residual output's important, and there's preclinical data that supports that we actually need to mop up that last little bit. So you're talking about needing to really tightly control this pathway, and I'll admit that one problem with the types of semi-quantitative evidence that I show you here is that we need more quantitative readouts, MAP kinase pathway transcriptional output, for example, which is a viable strategy for trying to understand increments in control of the pathway. But I think that's much of the secret is there, I think.
It may even be that to really put your finger in the dam and stop it, you might even need an ERK inhibitor or MEK inhibitor.
Precisely. Yeah, I'll take everything one can give us, in terms of pharmacologic material in this pathway. I think there's reason, the data continues to speak to the fact these tumors care about this pathway and they're not giving up on it, even with combined BRAF MEK inhibition. So there may be room for improvement in the types of BRAF inhibitors that we're using, maybe even in the MEK inhibitors, and then certainly other points of intervention, and maybe even further downstream at the level of risk, for example, is reasonable to justify.
So when you're saying you need a higher the inhibition on the MEK,
right?
But you also mentioned about tox, right? So how are you going to manage this?
Right. So I mean, if it hasn't come up already in this conference, I'd make the comment that it's possible that higher grade inhibition of the pathway here by looking at normal tissue won't be tolerated continuously, and you have to be looking at interrupted schedules, intermittent dosing of these types of therapies to be able to achieve 99.9% inhibition in the tumor and high grade inhibition in normal tissue. That just you can't sustain that in the longer term. I'm perfectly interested in that hypothesis. We haven't been pushed towards interrupted schedules yet, based on the data that I've shown you with these agents thus far. But if, for example, BRAF MEK combination, if we were to really push into true dose-limiting toxicity type regimens with the two drugs at higher than standard doses of each drug, we may then need to relax and offer a washout period for normal tissue recovery. Whether that'll compromise efficacy, to do that, we have to find out. But that's one strategy to try to overcome that.
So 2 last questions, James.
So yesterday, Dr. Chapner raised the question of using chemotherapy along with some of these new generation kinase inhibitors. The idea being that having a completely orthogonal mechanism would reduce the likelihood of getting acquired resistance.
Right.
This particular disease seems like it's actually quite amenable to that from the standpoint of looking at inhibitors of the nucleotides that are in the system, the GTP, And also because the rate-limiting enzyme for making the guanine ribonucleotides, in those cases of tumors where P53 is wild type,
Right.
those tumors are particularly, their growth is particularly related to the levels of IMPDH.
Right.
So I'm wondering, have other types of nucleotide inhibitors been looked at in combination with these?
No, it's a good point. I'll admit that I give almost no podium time to the concept simply because in the broad history of cancer chemotherapeutics, conventional cytotoxics in melanoma, despite being P53 wild type, they have such little signal that I would say we're not compelled there on clinical grounds, right? The field, myself included, we're very enthusiastic to just basically leap over cytotoxic chemotherapy and assemble combination targeted therapy regimens, combo targeted immuno regimens. But you may well be right. We might actually be unmasking now a susceptibility that isn't there inherently. It is conceivable, and I'm certainly willing to entertain that hypothesis. Of course, our own group, I already made mention of 6 or 7 trials that we're launching right now in our group, and we're not that huge a program. So somebody should sort out the precise mechanism by which we could leverage
Last
that
question,
dependence.
Lou.
I was interested in your comment that the dual mutant were perhaps less fit
Yep,
than the
yep.
BRAF. So if they're really less fit, like a lot, they should disappear from the population. And so the
Right.
question is, are they really? They can't. Maybe they have something else that is they're better than the BRAF single, the doubles, and that's why they stick around. So the question is, can you monitor on a single cell basis
Right.
how many of these are there, and are they, if they were at the 0.001%, then I'm saying, okay, maybe they are deleterious to have the double, they're diluted out.
Right.
But if they were at 1% or something like that,
we
then they have a different fit.
pretty clear. We aren't getting any signal that they're present at the 1% level, but we have not adequately mapped that out, nor have we adequately characterized at the single cell level. So this is work yet to be done. What I'd reiterate one point that I made, which is if you just look at melanoma samples, deep sequencing with good coverage that are unperturbed, you will rarely, there are 2 reports out of hundreds and hundreds and hundreds in the published literature of patient tumor samples that have both the BRAF and NRAS mutation existent in the untreated state, right? So it seems to be a rare event to find that as the dominant subclone.
Exome or by targeted sequencing?
This is targeted sequencing. The first pass, meaning like the 2004 or 5 era reports were targeted sequencing.
But not with deep
Now,
amplicon
but that's been
sequencing.
but more recently it's been deep across not just TCGA but other platforms. The Cell paper, for example, made the same point that basically you just don't find these concomitant strong oncogenes being present in the natural history of the disease, and yet 20% of cases emerge with them. Whether it's an admixture, as you're suggesting, it could be. We need to rule that out more completely, but it looks like they are a low frequency population, but how low we don't yet know. And I to be clear, I'm posing all of that as hypothesis in terms of really proving that's the biology behind it.
Great. Keith, that was fantastic. Thank you very much.